So I've been looking through these clinical notes, and the human neck. It feels less like a piece of anatomy and more like a high-stakes puzzle box.
It really is.
You have this incredibly dense geography, nerves, glands, vessels, all just packed in there. And when an X marks the spot, like with a mystery lump, you can't just start digging.
It's a minefield, really. Margin for error in the neck is it's basically zero. You put a scalpel in the wrong spot, or even just press too hard, and you could be looking at permanent, life-altering damage.
Right.
It takes a very specific kind of discipline to figure these things out without just cutting someone open right away.
Well, that's the tension I want to get into today. We have these two cases here, two men, both with these pretty substantial neck masses, about 8 centimeters each.
Which is not small.
No, that's like a baseball. But what struck me is that even though the lumps are a similar size, the actual detective work to figure them out is completely different, just based on a few inches of geography.
Oh, location is everything here. We're looking at one case in the submandibular region.
Under the jaw.
Yep, level IB, and the other is in the parotid region. And while the final diagnosis might end up being similar, the road to get there is all about understanding that local architecture. It's a masterclass in clinical anatomy.
Okay, so let's start with that first case. We have an elderly male patient. He's comfortable, not in any distress, which is a good sign. But he has this single ovoid swelling in the left submandibular area. The notes say it goes from the midline all the way back to the sternocleidomastoid.
And just visualizing that, you realize how dominant this mass is. I mean, it's taking up the entire digastric triangle. When a clinician sees that, the list of possibilities is, well, it's long.
Could be anything.
A lymph node, a cyst, a tumor, an infection. The goal is to start whittling that list down before you even reach for an ultrasound.
And the process they used here is fascinating. A series of almost simple-seeming physical tests, but they're so effective. Like the Valsalva maneuver, they just had him pinch his nose and blow. And the notes say the swelling did not change size.
Which is a critical negative finding. If that mass had puffed up, we'd be thinking about a laryngocele.
An air sac.
An air-filled sac coming off the larynx, yeah. The fact that it stayed put tells us there's no connection to the airway. It's solid, or it's fluid-filled, not air.
But then they moved to the light test. Transillumination. I always associate this with checking fluid somewhere else. But here they're looking for a plunging ranula.
Yeah, a plunging ranula is just a mucus retention cyst that dives down from the floor of the mouth. It's full of this clear, thin mucus, so it should light up like a lantern.
And in this case?
It was dark, non-transluminant.
Okay, so it's solid. We've ruled out air, ruled out a simple bag of fluid.
Yeah.
That brings us to the plumbing, right? The submandibular gland is a saliva factory, so my first thought was a blockage, like a stone.
Silolithiasis, a very common culprit. But the clinical exam notes are very specific here. They did an intraoral exam.
Feeling inside the mouth.
And they found the opening of Wharton's duct under the tongue.
And they milked the duct, which is a vivid term.
It is, but it means they pressed along the gland to see what came out.
And it was clear saliva.
That's a huge clue. If this was chronic silodinitis or a big stone, you'd expect pus or maybe thick, cloudy saliva or nothing at all. The fact that it's draining normally suggests the plumbing itself is okay.
So the mass isn't a blockage. It's something growing in or around the gland tissue itself.
Precisely, and the bimanual palpation confirmed it. No stones, so you're left with a firm, mobile mass with well-defined edges.
And the skin over it is normal. The nerves are working fine. His lower lip isn't drooping, which means the marginal mandibular nerve is okay.
And that preservation of nerve function is probably the strongest indicator against malignancy at this stage. Malignant tumors, they tend to invade things, they grab onto nerves, they tether themselves to bone, making the mass immobile. This thing is, well, it's being polite to its neighbors.
Polite to its neighbors. I like that. So putting it all together, firm, mobile, painless, polite, the provisional diagnosis is a benign neoplasm, specifically a pleomorphic adenoma.
The benign mixed tumor. Statistically, it's the most likely suspect for a lump in the submandibular gland. It's slow growing, not cancer, but it doesn't stop growing, it just keeps getting bigger.
Okay, let's pivot to our second guy, case B. A middle-aged man, also an 8-centimeter lump, but this one's in the right preauricular area, right in front of his ear, and the notes say it's actually deflecting his earlobe outward and filling in the groove behind his jaw.
The obliteration of the retromandibular sulcus, that visual cue just screams parotid. The parotid gland wraps around the back of the jaw, so when it swells, it fills that hollow space.
And here's where the detective work gets really clever. They checked the mobility of this lump, just like the first one, but the result was specific. It says the mass moved side to side, horizontally. It was fixed vertically. It couldn't move up and down.
And that is one of those beautiful aha moments in clinical anatomy. It's all about the parotid fascia. Okay, it's this tough, dense sheet of connective tissue that wraps the gland. And crucially, it's anchored to the zygomatic arch, the cheekbone above, and to the mandible below.
So it's suspended.
Think of it like a hammock bolted to the wall at both ends. You can swing it side to side, but you can't slide the whole thing up and down the wall. The tumor is trapped inside that fascial hammock, so it has the same restrictions.
That is so cool. It's a purely mechanical confirmation. You don't need a scan to tell you it's parotid.
Exactly. It immediately tells you it's not something like a lymph node or a skin cyst, which would be on top of the fascia and would slide around in any direction.
Now, they mentioned another physical test for this case, assessing the deep lobe. The notes say the exam suggested it wasn't involved. How did they figure that out? Just by feel?
That's a specific bimanual technique. You have one finger inside the patient's mouth against the back of the throat near the tonsil, and the other hand on the cheek over the mass. You're feeling for something called ballottement.
Ballottement. Like?
Yes. If the tumor goes deep, it pushes inward toward the throat. You could push the mass from the outside and feel it bounce against your finger on the inside. If you can't feel that, the tumor is likely confined to the superficial part of the gland.
Which I imagine makes a huge difference to the surgeon. But structurally, this guy matches the first one. Facial nerve is working, mass is firm, but mobile, at least horizontally. So are we looking at another pleomorphic adenoma?
Almost certainly. Same pathology, different address.
So we have our suspects. Now we need to confirm them. The notes lay out a clear investigation pathway. First up is ultrasound. I assume that's just the quick and easy first look.
It's the triage tool. It confirms the mass is solid, gives you precise measurements. It can also spot blood flow, which might hint at something else. But it doesn't tell you the cell type.
For that, they used FNAC, fine needle aspiration cytology. I know some patients worry about this idea that poking a tumor with a needle will spread it.
That's a very common fear, but in this context, it's largely unfounded. FNAC is the gold standard for a reason. We use a very fine needle, and the risk of tumor seeding along the needle track for these is infinitesimally small.
And the benefit is huge.
You cannot walk into that operating room without knowing the cell type. If it comes back as high-grade cancer, the whole plan changes. You might need to take lymph nodes, maybe even sacrifice nerves. You need that roadmap.
Speaking of roadmaps, imaging. MRI versus CT. The notes really prefer MRI, especially for the parotid case. Why the magnet over the X-ray here?
It's all about soft tissue resolution. CTs are great for bone, but in the neck they can get noisy, especially with dental fillings. MRI gives you this pristine, high-contrast view of the soft tissues.
And for the parotid, you're trying to see the nerve path.
Indirectly, yes. You can't always see the nerve itself, but you see the plane between the deep and superficial lobes. You can see how the tumor relates to those structures. MRI helps you predict how difficult that facial nerve dissection is going to be.
Okay, let's get these things out. Diagnosis is confirmed. We're going to surgery. And this isn't just cut it out, is it? It's incredibly technical.
Yeah.
Let's start with case A, the submandibular mass. The rule is excision of the entire gland.
Correct.
But the notes have this warning in bold. No nucleation. You can't just shell it out like a pea from a pod. Why? If it's benign, why does the whole gland have to go?
It comes down to the microscopic behavior of these tumors. To the naked eye, they look like they have a nice, smooth capsule, but under a microscope, that capsule is deceptive. The tumor sends out these tiny microscopic finger pseudopods that push through the capsule.
Just not a smooth marble, it's more like a fuzzy tennis ball.
Exactly. And if you try to just scoop it out along that visible edge, you will inevitably shear off those microscopic fingers. You leave tumor cells behind, and the recurrence rate is notoriously high if you do that.
And I'm guessing a recurrence is much harder to treat.
It's a nightmare. It doesn't come back as one lump. It comes back as hundreds of little pearls of tumor scattered through the scar tissue. Cleaning that up without damaging the nerves is incredibly difficult. So the first surgery is your best shot.
Yeah.
Take the whole gland.
But taking the submandibular gland means you're operating in a really busy intersection. You've got the lingual, the hypoglossal, and the marginal mandibular nerves right there.
It's a very dizzy neighborhood. The lingual nerve is particularly vulnerable. It loops right under the duct. You damage that, you lose sensation and taste on that side of the tongue. The hypoglossal moves the tongue, and the marginal mandibular, of course, controls the smile.
Wow. And if that sounds stressful, the parotid surgery for case B, that sounds absolutely terrifying. The superficial parotidectomy.
This is the Everest of head and neck surgery for a lot of residents.
Yeah.
The problem is that the facial nerve doesn't just run near the gland, it runs through it.
Right through the middle.
It enters as one trunk and then branches out like a goose's foot. The pes serina splitting the gland into a superficial and a deep lobe.
So the tumor is basically sitting in a sandwich made of gland tissue and the nerve that controls your entire face.
And the tumor is often stuck to those nerve branches. The surgery is about finding the main trunk of the nerve and then painstakingly dissecting each branch away from the gland. You are literally shaving the tumor off the nerve.
And that nerve is what? The thickness of a piece of string?
Less. The branches are incredibly delicate. You're constantly using an electrical stimulator to monitor them to make sure you're not damaging them while you work.
Okay, so let's assume the surgeon has the hands of a watchmaker and they get the tumor out.
Yeah.
There are still some bizarre complications that can happen. We have to talk about Fraze syndrome.
Gustatory sweating. It is one of the most curious things in medicine.
The notes describe it as sweating on your cheek when you eat. That just sounds like a wiring error.
That is precisely what it is. It's called aberrant reinnervation. When you remove the parotid gland, you cut the little parasympathetic nerve fibers that used to tell the gland to make saliva. During healing, those cut nerve ends, they're looking for something to connect to. They're trying to find their old job.
But the gland isn't there anymore.
Exactly. So in their confusion, they grow upward and they connect to the sweat glands in the skin flap you laid over the surgical site.
So the brain sends a signal saying, that food looks good, make saliva. But the skin hears, release sweat.
The wires get crossed. The stimulus for digestion produces a sweat response on the face. It's usually mild, but for some people, it can be pretty distressing to have sweat dripping down their cheek every time they sit down for a meal.
It just shows how the body has its own logic when it heals, doesn't it? It doesn't always follow the original blueprint.
No, it prioritizes connection over function sometimes.
The other complication they mentioned is acylocele, which sounds wet.
It is. It's a collection of saliva under the skin. It can happen if a little bit of secreting gland tissue gets left behind, or the cut surface just keeps leaking. Since there's no duct anymore, it just pools up.
A pocket of spit in your cheek.
Pretty much. It usually resolves on its own, maybe with some pressure or aspiration, but it can be a nuisance.
Stepping back from all the surgical stress, though, the prognosis for both of these patients is actually really good.
Oh, that's excellent. If it is a pleomorphic adenoma and it's removed completely with clear margins, no capsule rupture, the cure rate is over 95%. They just go on to live normal lives.
And losing one major salivary gland isn't a huge deal.
Not really. We have thousands of minor salivary glands. The body compensates easily. Dry mouth isn't usually a long-term issue.
That's a relief. It's just amazing to trace this whole journey. We started with two lumps that, from the outside, looked almost identical. But just by using gravity, light, pressure, and anatomy, we could predict exactly what they were and where they lived.
It really validates the importance of the physical exam. In an age where we can MRI everything, the hands and eyes of a good clinician are still the most efficient tools we have. We knew 90% of the story before the patient ever saw a scanner.
And we also saw that benign does not mean easy. The surgical planning needed to navigate that minefield of nerves is just humbling.
It's a reminder that anatomy isn't a static map. It's a functional, living system that you have to respect.
I want to leave our listener with a final thought on that idea of crossed wires and Fraze syndrome. We think of surgery as a fix, cut the bad part out, stitch it up, everything's back to normal. But Fraze syndrome shows that the body, it has its own agenda. It's just desperate to reconnect, even if the new connection makes no logical sense.
It's that biological drive for continuity.
Exactly. Nerves for saliva hijacking sweat glands. It makes you wonder, how many other little glitches or crossed wires are we all walking around with? Remnants of old injuries or surgeries where the body just improvised a solution that we haven't even noticed yet.
That's a provocative thought. We're probably all just walking mosaics of those little repairs.
A comforting or maybe a slightly unsettling thought to end on. Thanks for diving deep into the detective work of the neck with us.
My pleasure.
Keep your eyes open, and we'll see you on the next deep dive.